Hello, pharmacology friends. I would like to talk to you today about bipolar disorder, type 1 and 2, and mainly our top choice for treatment, which is lithium. First of all, I just want to make a characterization. There are two subtypes of bipolar disorder. There's bipolar 1 and bipolar 2. Bipolar 1 is generally what's portrayed, I think, in the media as main bipolar disorder. And bipolar disorder is literally bipoles, two poles. So you have the swinging of mood or the cycling of mood from these really intense manic states to depressive states. And if there's at least one observable manic episode, at least in the year, which generally people don't seek treatment during, and they don't seek treatment during it because it generally feels good. There's euphoria, this sense of grandiosity, hypersexuality, energy goes up, the need for sleep goes down. If there is an episode that severely impacts life, especially if it results in hospitalization, that generally garners a diagnosis of bipolar type 1 disorder. Bipolar type 2, however, doesn't involve such intense bouts of mania. Instead, what we see is hypomania, and remember that hypo means below. So hypomania falls below severe mania, and to some patients, they describe it more so as a really intense surge of energy or productivity or creativity, but there's no psychotic symptoms that go along with it. And then there's less social disruption. So you might not see hospitalization or arrest like you might see in bipolar 1. I want to make a note that in general, about 70% of those diagnosed with bipolar disorder receive an incorrect diagnosis to begin with. Why is that? Again, manic episodes generally don't garner the need for somebody to go seek medical treatment. They feel good, they feel productive, whereas mainly you'll see people seeking treatment during a depressive episode. And if somebody presents with major depressive symptoms, generally they're treated for depression, which is why usually there's a misdiagnosis first. Why that's important to take into account is that if somebody is misdiagnosed or mistreated, we see that not only does having bipolar disorder take about 2 years off of lifespan in general, but 1 out of 4 to 5 patients actually complete a suicide, mostly when they're misdiagnosed and mistreated, because some medications used for depressive disorders can start a manic episode, start a major depressive episode, and we see really poor outcomes. That being said, it's important to get a correct diagnosis, find a great tool. There are several great screens that are available online through different organizations. There's also the DSM. Once there is a good diagnosis, pharmacologic therapy is important. A lot of people that start these medications for bipolar disorder will be on them for life if they comply or adhere to their regimen. The fact that generally manic episodes are experienced in positive light, especially with bipolar type 2, where rather than the mania being the predominant symptom, these depressive episodes, low-level depression that's long-standing is the predominant feature. So when a manic or hypomanic episode hits, it's definitely more preferable than a depressive episode. So only a third of patients diagnosed with BPD 1 or 2 are on pharmacotherapy. And when it is necessary to start pharmacotherapy is when, again, you have this episode of hypomania or mania and depressive symptoms that occur as episodes. So a depressive episode or a manic episode. Certain things can trigger these mood fluctuations in episodes. So they can be stress related, either psychological or physiologic stress, certain medications, big life changes, moving from night shift to a day shift, making a move, starting a new job or school program, drug and alcohol abuse. And it is important for me as an addiction scientist to mention that alcoholism or alcohol misuse, alcohol use disorder is comorbid with bipolar disorder. 30% of patients with bipolar disorder also have a diagnosable alcohol use disorder, so it meets criteria. One of the biggest things that can maybe be if you are making this diagnosis, so something that might clue you in that it may be bipolar depression rather than unipolar depression, is whether or not it follows a seasonal pattern. That's something that's overlooked quite a bit, where somebody gets a lot of energy and they feel really great in the spring and they tend to get really depressed in the winter. Believe it or not, that can be bipolar too, not just typical seasonal changes. So once there is a diagnosis, the major medication goal is reducing the fluctuation of mood from these really extreme, from hypomania or mania to depression. We want to use something that will stabilize that and reduce the frequency then of episodes. Because remember, for especially bipolar 1, when there is a manic episode, they can be so severe that we get hospitalization. There is only one true mood stabilizer on the market, and it's our old school medication, lithium, which remains the top choice of treatment for today. Not everybody can tolerate lithium, and some people are treatment resistant with lithium alone. So there are medications that can either be used alone or adjunct to lithium. And these are medications that are typically used for epilepsy. So they include valproic acid, lamotrigine, carbamazepine, all medications used for seizures, but bipolar disorder seems to share an etiology or at least a pathogenesis that is similar. So what you see here on this table is the list of medications that are approved to treat bipolar disorder, type 1 and type 2. We also have the doses there if you're interested in that. But I have starred, look at that pretty star, our lithium carbonate, because that, again, that's our only mood stabilizer. And this is in contrast to all of the other medications like our Depakote, lamotrigine, gabapentin, carbamazepine, and then Topamax and trileptal, Tegretol. Those not only are anti-convulsants, but they're also used in the treatment of migraine. And maybe I'll do a video on this pathogenesis. It seems like migraine, mania, and seizures all go along with this interesting kindling theory, and they seem to spread along the brain through gap junctions that make the neurobiology or the neurophysiology really interesting. So you will see a lot of overlap in the treatment for those. But I want to just focus on lithium for the time being. Focus on lithium, which remains the first line treatment, especially in bipolar type 1. Bipolar 2 has a little bit of a different presentation, so we might see anti-convulsants used more often as a pharmacotherapy that is primary, whereas with bipolar 1, lithium remains the main choice. So if you remember chemistry, who doesn't? You might remember lithium is on the periodic table. Like, that's how small it is. It's this little, light alkali metal, and it looks really similar to sodium. That's important for later. It also looks really similar to iodine, also important for later. When you give a neurotypical individual lithium, there are no psychotropic effects, meaning there's no brain or behavior effects. There can still be general physiologic effects, which is definitely true, but that doesn't mean that they have a psychologic response. It is 60 to 80% effective in treating acute hypomanic and manic episodes, meaning if somebody is hospitalized for mania or hypomania, lithium is most of the time going to resolve that episode. Also going with the history of medications that I just love. In the 20s, it was used as an anti-convulsant. It turns out it wasn't great for that, so it was shelved for a little bit. In the 40s, that's when we started to see this link between diet and cardiovascular disease. So we started to see the rise of popularity in the low salt diet, or, limiting salt to limit blood pressure. Lithium, because it's a salty alkali metal, it worked really well as a salt substitute. So if you didn't want to sprinkle salt on your food, you could sprinkle some lithium on your food so you don't get the hypertensive effects. Turns out that did have some physiologic effects along with it for some individuals, because lithium is also a mood stabilizer. In 1949, it was involved in just a general lab trial. So imagine an animal laboratory with cages all along the wall filled with guinea pigs. And if you've ever been by a guinea pig, they call them pigs for a reason. When you walk by them and they think they're going to be fed, they squeak and they make a ton of noise and they're really excited about being fed. What they found is that when guinea pigs had lithium in their drinking water, they were far calmer. So those people working in the lab thought, hey, if it works for these loud guinea pigs, maybe it'll work in suppressing mood or mania in people. And in 1970, there was quite a bit of a jump there. They had to convince some people, but it was found to be clinically relevant in treating bipolar disorder. Why also it's important that we have other medications like the anticonvulsants on the market is we can pretty much, even though the numbers are, off, let's round them. About a third of patients discontinue lithium for a variety of reasons. The second third, a little over a third, they take, but they do have reoccurrences of mania or depressive episodes. And the last third, a little less than a third, they take lithium on its own and they have no further episodes. So some individuals are fine on lithium on its own. The other, greater than a third, might need an adjunct medication to enhance the mood stabilization properties of lithium. All right, so just our toxicities of lithium, because this is a metal. As mentioned before, all right, we're trying to get rid of this term noncompliance and use non-adherence so that it doesn't sound so terrible. Like, you're non-compliant. It's non-adherence to the pharmacologic regimen. And about 1 out of 2 patients against medical advice will stop taking their lithium. The main reasons that are cited are the intolerance to the side effects, like the cognitive issues, the memory and energy issues, the weight gain, and then missing the euphoric manic episodes. However, even though there are side effects that are not desirable, we have really important outcomes. When we have an appropriately treated patient with a great, on the nose diagnosis, lithium reduces suicidal behavior by about 80%. When somebody stops lithium, the rates of completed, so not attempted, but completed suicides increases 13-fold. So that's huge. So we want to make the medication as palatable as can be so that individuals continue taking it. And once lithium treatment is started, it may be necessary for the lifespan of that patient.